Good day. Today we'll present rabies. Rabies is primarily a disease of animals. Rabies virus is the prototype member of the genus Lyssavirus. All Lyssaviruses are adapted to replicate in the mammalian CNS, are transmitted by direct contact, and are not associated with transmission by or natural replication in insects. Major vectors of rabies in Asia include dogs, coyotes, and mongooses. Viral infection of the salivary glands of the biting animal is responsible for the infectivity of saliva. After a bite, saliva containing infectious rabies virus is deposited in muscle and subcutaneous tissues. The virus remains close to the site of exposure for the majority of the long incubation period of typically 20 to 90 days. Rabies virus binds to the nicotinic acetylcholine receptor in muscle, which is expressed on the postsynaptic membrane of the neuromuscular junction. Subsequently, the virus spreads across the motor end plate and ascends and replicates along the peripheral nervous axoplasm to the dorsal root ganglia, the spinal cord, and the CNS. Following CNS replication in the gray matter, the virus spreads outward by peripheral nerves to virtually all tissues and organ systems. Histologically, rabies is an encephalitis resulting in infiltration of lymphocytes, polymorphonuclear leukocytes, and plasma cells, and focal hemorrhage and demyelination in the gray matter of the CNS, the basal ganglia, and the spinal cord. Negri bodies, in which CNS viral replication occurs, are eosinophilic intracellular lesions found within cerebral neurons and are highly specific for rabies. Negri bodies are found in about 75% of proven cases of animal rabies. Although their presence is pathognomonic for rabies, their absence does not exclude it. Transmission of rabies virus usually begins when the contaminated saliva of an infected host is passed to a susceptible host, usually by the bite of a rabid animal. Other routes of documented transmission include contamination of mucous membranes, such as the eyes, nose, and mouth, aerosol transmission during spelunking or caving in bat-infested caves, exposure while working in the laboratory with rabies virus, infected organ transplants, such as cornea, liver, kidney, vascular grafts, and lung, and iatrogenic infection through improperly inactivated vaccine. Pre-exposure prophylaxis with the rabies vaccine is highly recommended for persons whose recreational or occupational activities place them at risk for rabies. These include the following risk categories: continuous, frequent, infrequent, which is greater than the population at large, and rare, which is at the population at large. The nature of continuous risk is that the virus is present continuously, often in high concentrations. Specific exposure is likely to go unrecognized, and it may be transmitted via bite, non-bite, or aerosol exposure. The typical population in continuous risk include rabies research laboratory workers and rabies biologicals production workers. Pre-exposure recommendations have a primary course of serologic testing every 6 months with a booster immunization if the antibody titer is below acceptable levels. For frequent risk, these are people who have usually episodic exposure with source recognized, but exposure may also be unrecognized, and this may be through bite, non-bite, or aerosol exposure again. So these include rabies diagnostic laboratory workers, cavers, veterinarians and staff, animal control and wildlife workers, and in rabies endemic areas, all persons who regularly handle bats. Primary course is serologic testing every 2 years and booster immunizations if antibody titer is below acceptable level. Infrequent risk classifies people who have nearly always episodic exposure with source recognized, either through bite or non-bite exposure. These include veterinarians and animal control and wildlife workers working with terrestrial animals in areas where rabies is uncommon or rare, veterinary students, travelers visiting areas where rabies is endemic, and immediate access to appropriate medical care, including biologicals, is limited. No serologic testing or booster immunization is required. And for rare risk category, this is for people whose exposure is always episodic with source recognized, either through bite or non-bite exposure. This includes the population of developed countries at large, including persons in rabies endemic areas. Although the initial rabies pre-exposure vaccine regimen is similar for all risk groups, the need for booster doses, the timing of booster doses, and the need for and timing of serologic tests to confirm immunity differ based on the degree of individual risk for exposure to rabies. Pre-exposure prophylaxis may be obtained from the local health department or from a local physician or veterinarian. Pre-exposure vaccination does not eliminate the need for additional therapy after a rabies exposure, but simplifies post-exposure prophylaxis by eliminating the need for human rabies immunoglobulin and by decreasing the number of doses of vaccine required. When it comes to rabies pre-exposure prophylaxis schedule, in the United States in particular, there is primary or booster type immunization. Both are given through intramuscular route. The regimen for primary immunization is HDCV or PCECV 1.0 ml at the deltoid area, one dose on days 0, 7, 27, or 28. So that's required on days 0 and 7, and you may choose between the 21st or the 28th day. For boosters, it is the same HDCV or PCECV 1.0 ml at the deltoid area with one dose on day 0 only. The deltoid area is used for adults and older children. For young children, we use the anterolateral thigh. Do not administer the vaccine in the gluteal area. Persons in the continuous risk category should have a serum sample tested for rabies neutralizing antibody every 6 months, and persons in the frequent risk category should be tested every 2 years. An IM booster dose of vaccine should be administered if the serum titer falls to maintain the value of at least complete neutralization at a 1:5 serum dilution by a rapid fluorescent focus inhibition test. The risk of developing rabies following a bite or scratch by a rabid animal depends on whether the wound was a bite, scratch, or non-bite exposure, the number of bites, depth of the bites, and the location of the wounds. Risk assessment for post-exposure prophylaxis includes determining the epidemiology of animal rabies in the area where the contact occurred, knowing the species of animal involved, understanding the type of exposure, be it bite versus non-bite, clarifying the circumstances captured and tested, or rather clarifying the circumstances of the exposure incident, and determine if the animal can be safely captured and tested for rabies. The distinction between a provoked and non-provoked attack should not be used for risk assessment. Most animal bites are provoked from the standpoint of the animal, such as interfering with the animal's food, offspring, feeding habits, etc. In addition, about 15% of animals with rabies do not exhibit aggressive behavior but are apathetic, which is also known as dumb rabies. The local health department can provide information about the epidemiology of animal rabies in the area. Evaluation for post-exposure prophylaxis is indicated for persons bitten by, scratched by, or exposed to saliva from a wild or domestic animal that could be rabid. The risk of rabies in the absence of post-exposure prophylaxis after exposure to a rabid animal, if the patient has multiple severe bites around the face, it's at 80 to 100%. For a single bite, 15 to 40%. Superficial bites on an extremity, 5%. Contamination of a recent wound by saliva is approximately 0.1%. Contact with rabid saliva on a wound older than 24 hours is 0%. Transmission via fomites, such as in tree branches, is theoretical, and indirect transmission, such as raccoon saliva on a dog, is also theoretical. We give post-exposure prophylaxis as soon as possible after exposure to rabies-prone wildlife. For the purpose of rabies post-exposure prophylaxis, a bite exposure is defined as any penetration of the skin by the teeth of an animal. Bites to the face and hands carry the highest risk, but the size of the bite does not influence the decision to begin therapy. A non-bite exposure is contamination of scratches, abrasions, open wounds, or mucous membranes with saliva or brain tissue from a rabid animal. For example, animal licks to non-intact skin have transmitted rabies. Non-bite exposures from animals very rarely cause rabies. If the material containing the virus is dry, the virus can be considered non-infectious. Petting a rabid animal or contact with blood, urine, or feces, such as guano, of a rabid animal does not constitute an exposure and is not an indication for prophylaxis. A fully vaccinated dog or cat That is, a dog or cat that has received two vaccinations is unlikely to become infected with rabies. No documented vaccine failures have been reported in the United States among dogs or cats that received two vaccinations. Rare cases have been reported among animals that have received only a single dose of the vaccine. In the United States, animals other than dogs, cats, and ferrets that can transmit rabies and are the source of an animal bite or scratch to a human should be euthanized and tested for rabies even if the animals have been vaccinated. Any direct contact between a human and a bat should be evaluated for rabies exposure. Seeing a bat does not constitute an exposure. Post-exposure prophylaxis is not indicated if the person can be certain that a bite, scratch, or mucous membrane exposure did not occur, or if the bat is available for testing and the results are negative for the presence of rabies virus. All bats that might be a source of exposure, if available, should be sent to the public health department and tested for rabies because approximately 94% of submitted bats, at least in the United States, have tested negative for rabies. The Advisory Committee on Immunization Practices recommends consideration of post-exposure prophylaxis for persons who were in the same room as a bat and who were unaware if a bite or direct contact had occurred, such as a sleeping person who awakens to find a bat in the room, or an adult witnesses a bat in the room with an unattended child, mentally disabled person, or intoxicated person. One article calculated the incidence of rabies following bedroom exposure with contact as 0.6 cases per billion person years, whereas another article reported that the number needed to treat to prevent a single case of rabies in this context would be 314,000 to 2.7 million persons. The CDC recommends that a healthy dog, cat, or ferret that bites a person be confined and observed for 10 days. At the first sign of illness during confinement, such animals should be evaluated by a veterinarian and a report immediately made to the local health department. If signs suggestive of rabies develop, the animal should be euthanized and its head removed and shipped under refrigeration, but not frozen, for examination of the brain by a qualified laboratory designed by the local or state health department. Any stray or unwanted dog, cat, or ferret that bites a person may be euthanized immediately and the head submitted for rabies examination. Animals that might have exposed a person to rabies should be reported immediately to the local health department. An animal other than a dog, cat, or ferret that received prior vaccination may still require euthanasia and testing if the period of virus shedding is unknown for that species. There are anecdotal reports of person to person transmission of rabies. Fluid from the upper and lower respiratory tracts of humans frequently test positive for the rabies virus. Despite the lack of proven healthcare associated transmission, about 30% of healthcare personnel who have had contact with a human diagnosed with rabies have received post exposure prophylaxis. Given the mechanism of disease in transmission and concern among healthcare workers, contact isolation precautions should be used for patients with known or suspected rabies, and healthcare workers who care for such patients should wear either masks and eye protection or face shields. Healthcare personnel with non intact skin or mucous membrane exposure to infective saliva from patients with rabies should receive post exposure prophylaxis. For unusual exposures, a veterinarian or the local public health agency can be contacted for more information. However, for patients who voice concern about rabies exposure, even if the risk assessment is virtually nil, vaccination can be offered along with an explanation of the risks and benefits of vaccination. If the risk of rabies is virtually nil, we discourage the administration of HRIG. First, we assess the wounds for the presence of a life-threatening condition, such as arterial laceration or pneumothorax. We provide proper wound care, including tetanus prophylaxis, wound cleansing with soap and water, and if available, a dilute solution of povidone iodine. 1 ml of povidone iodine is placed in 9 ml of water or normal saline. Antibiotics if indicated to prevent bacterial infection, and rabies prophylaxis as indicated. So 2012 rabies post-exposure risk assessment and recommendations are the following. For dogs, cats, and ferrets, evaluation and disposition of the animal is done if healthy and available for 10 days of observations, if rabid or suspected rabid or unknown such as escape. Recommendations for post-exposure prophylaxis is that persons should not begin vaccination unless the animals develop clinical signs of rabies. Immediate immunization may be done if the animal is rabid or suspected rabid. And if the status of the animal is unknown, we consult public health officials. For skunks, raccoons, foxes, and most other carnivores, as well as bats, we regard as rabid unless the animal proven negative for rabies virus by laboratory test and consider immediate immunization. For livestock, horses, rodents, rabbits, and hares, and other mammals, we consider individually and consult public health officials. Bites of squirrels, hamsters, guinea pigs, gerbils, chipmunks, mice, rats, rabbits, hares, and other small rodents almost never require rabies post exposure prophylaxis. During the 10-day observation period for healthy dogs, cats, and ferrets, begin post exposure prophylaxis at the first sign of rabies in a dog, cat, or ferret that has bitten someone. If the animal exhibits clinical signs of rabies, it should be euthanized immediately. Clinical guidelines for administration of post exposure prophylaxis are as follows. We consider post exposure prophylaxis for persons who were in the same room as a bat and who might be unaware that a bite or direct contact had occurred. The small mammals listed here have never been reported to transmit rabies to humans in the United States, but theoretically, such animals could acquire and transmit rabies. Therefore, post exposure prophylaxis following a bite or scratch from one of these animals would only be indicated if such animal had signs typical of rabies or a positive laboratory test for rabies. So, the animals that are included in the list of small mammals that have never been reported to transmit rabies are birds, reptiles, rodents, such as hamsters, squirrels, guinea pigs, gerbils, mice, rats, or rabbits. So the algorithm begins with collecting information such as the animal species, salivary exposure to the wound or mucous membrane, and whether the animal is available for observation. If there is a lab incident with known rabies virus exposure to wound or mucous membranes or significant inhalational exposure, we give the vaccine and HRIG. For a carnivore or bat with bite or salivary exposure, if it's a dog or cat and it escaped, epidemiologic absence of rabies risk in the species and geographic area means that prophylaxis is not needed. But if epidemiologic rabies exists for the species in the geographic data or there's inadequate data, we give vaccines and HRIG. For other carnivores such as skunks, raccoons, cows, bobcats, coyotes, fox, or bats, if the animal has escaped, we give vaccine and HRIG. For dogs or cats that were captured and quarantined, if they exhibit strange behavior at capture or subsequently under observation, we euthanize the animal, refrigerate it, and send to a qualified lab. We examine the brain for Negri bodies and FAT standing for fluorescent antibody testing, initiate the vaccine plus HRIG pending results of examination. If the animal is rabid, we give the full course of the vaccine plus HRIG. If the animal is not rabid, we discontinue the vaccine because prophylaxis is not needed. But if the animal captured has normal behavior for 10 days, we release the animal and we do not give prophylaxis. Post exposure prophylaxis consists of a regimen of one dose of HRIG, if applicable, and four doses of rabies vaccine over a 14-day period, except for immunocompromised persons who should receive a 5-dose series of vaccine over a 28-day period. The shift from a 5-dose to a 4-dose series of rabies vaccine occurred in 2010 and is based on rabies virus pathogenesis, experimental animal studies, clinical trials, epidemiologic surveillance, and economic analyses. No other aspects of post exposure prophylaxis were altered from the 2008 recommendations, such as the use of HRIG, the site of injection, etc. HRIG and the first dose of rabies vaccine should be given as soon as possible after exposure, preferably within 24 hours. If HRIG was not administered when vaccination was begun, it can be administered up to 7 days after administration of the first dose of the vaccine. We followed the Centers for Disease Control and Prevention recommendations for post exposure prophylaxis exactly. Although no post exposure prophylaxis vaccine failures have been reported in the United States since the licensing of human diploid cell vaccine in 1980, 13 persons outside the United States have contracted rabies after post exposure prophylaxis with tissue culture derived vaccine. Each of these cases involved deviation from the recommended protocol, wounds were not cleansed, passive immunization with HRIG was not provided, or the rabies vaccine was injected into the gluteal rather than the deltoid area. Rabies vaccines that are available include human diploid cell vaccine and purified chick embryo cell culture vaccine, also known as PCECV, which is produced in chick embryo cells. The active antibody response requires approximately 7 to 10 days to develop, and detectable rabies virus neutralizing antibodies generally persist for several years. All currently used vaccines are produced in cell cultures and are significantly less toxic than older vaccines that were produced in neural tissue. Side effects of human diploid cell vaccine, including mild erythema, swelling, and pain at the injection site, have been reported in 10 to 90% of vaccine recipients. Systemic reactions such as headache, nausea, abdominal pain, muscle aches, and dizziness have been reported in 5 to 40% of recipients. Serum sickness like reactions, such as type 3 hypersensitivity, have been noted in approximately 6% of persons receiving booster doses of human diploid cell vaccine and occur 2 to 27 days after administration of the booster dose. Such reactions have not been life threatening and have not been reported with purified chick embryo cell culture vaccine. Anaphylaxis and neurologic symptoms have only been rarely associated with the current rabies vaccines. Severe egg allergy, however, is a contraindication to the use of purified chick embryo cell culture vaccine. Rabies prophylaxis should not be interrupted or discontinued because of mild or local systemic adverse reactions to the rabies vaccine. Usually, such reactions can be successfully managed with an anti-inflammatory and antipyretic agents. When a person with a history of serious hypersensitivity to the rabies vaccine must be revaccinated, antihistamines may be given. Epinephrine should be readily available to counteract anaphylactic reactions, and the person should be observed carefully immediately after vaccination, as after any other injection given in a healthcare setting. The summary of risk of acquiring rabies are as follows. Moderate to high risks occur with bites by skunks, raccoons, foxes, and other wild carnivores unless the animal tested negative for rabies, bite or direct contact with a bat unless the animal tested negative for rabies, exposure by percutaneous injury, mucous membrane exposure, or inhalation to live rabies virus in a laboratory, dog bite in a country with endemic rabies and inadequate immunization of dogs, or a bite by a feral dog. Low to very low risk includes bite by an adequately vaccinated cat or dog that has access to the outdoors or a feral cat or dog. Contamination of open wound or abrasion, including scratches with or mucous membrane exposure to saliva or other potentially infectious animal material, such as neural tissue, from a possibly rabid animal, such as a skunk, raccoon, fox, and other wild carnivores and bats, or awakening in a room with a bat present. No risk is identified in contact of animal fluids such as saliva, blood, and neural tissue with intact skin, or indirect contact with saliva from a wild animal, such as by cleaning a dog or cat that has had contact with a wild animal. Human rabies immunoglobulin, also known as HRIG, is administered only once at the beginning of anti-rabies prophylaxis to provide immediate antibodies until the patient responds to rabies vaccine by producing antibodies. A passive antibody titer is evident in 24 hours. Failure to administer HRIG has led to rabies despite appropriate post-exposure prophylaxis with human diploid cell vaccine. If HRIG was not given when vaccination was begun, it can be given through the seventh day after administration of the vaccine. Beyond the seventh day after vaccination is begun, HRIG is not indicated because an antibody response is presumed to have occurred. The CDC recommends that as much as possible, the full dose must be infiltrated around the wound. HRIG should never be administered in the same syringe or into the same anatomic site as the vaccine. Even if the wound has to be sutured, it should be infiltrated locally with HRIG. This practice is safe and does not create an additional risk of infection. However, caution is needed when injecting into a tissue compartment such as the finger pulp because excessive HRIG can increase compartment pressure and lead to necrosis. Any remaining HRIG that cannot be administered into the local wound area should be injected intramuscularly at a site distant from vaccine administration. HRIG is prepared from human blood and screened for known viruses such as HIV and hepatitis. No cases of virus transmission from HRIG that is commercially available in the United States or Australia have been reported. HRIG should not be given to those with immunoglobulin A deficiencies and known antibodies of immunoglobulin A because small amounts of immunoglobulin A may be present in HRIG and can cause a severe allergic reaction. The World Health Organization has provided recommendations for rabies post exposure prophylaxis that also consider the cost and availability of vaccines and HRIG. Per the WHO, the indication for post exposure prophylaxis depends on contact with the suspected rabid animal. Category 1 includes touching or feeding animals or licks on intact skin, that is, no exposure. Category 2 includes nibbling of uncovered skin, minor scratches or abrasions without bleeding. And Category 3 includes single or multiple transdermal bites or scratches, contamination of the mucous membrane with saliva from licks, licks on broken skin, and exposure to bats. For Category 1 exposures, no prophylaxis is required. For Category 2, immediate vaccination is recommended. And for Category 3, immediate vaccination and administration of rabies immunoglobulin are recommended. Per the World Health Organization, factors that should be taken into consideration when deciding whether to initiate post exposure prophylaxis include the epidemiologic likelihood of the animal being rabid, the category of exposure, be it 1, 2, or 3, and the clinical features of the animal, as well as its availability for observation and laboratory testing. In most situations in developing countries, the vaccination status of the implicated animal alone should not be considered when deciding whether to give or withhold prophylaxis. For IM administration, the World Health Organization recommends the following post exposure regimens. The post exposure vaccination schedule is based on injecting 1 ml or zero point 0.5 ml, volume depending on the type of vaccine, into the deltoid muscle or anterolateral thigh in children less than 2 years of age of patients with category 2 and 3 exposures. The recommended regimen consists of either a 5-dose or 4-dose schedule. The 5-dose schedule consists of one dose on each days 0, 3, 7, 14, and 28. The 4-dose schedule consists of 2 doses on day 0, with one dose on each of the two deltoid or thigh sites, followed by one dose on each of days 7 and 21. An alternative for healthy, fully immunocompetent, exposed persons who receive wound care plus high quality rabies immunoglobulin plus WHO pre qualified rabies vaccines is a post exposure regimen consisting of 4 doses administered intramuscularly on days 0, 3, 7, and 14. For intradermal administration, the World Health Organization recommends the following post exposure regimen. The two site regimen prescribes an injection of zero point 0.1 ml at two sites at the deltoid and thigh on days 0, 3, 7, and 28. So just to recap, the 5-dose schedule is 0, 3, 7, 14, and 28. Those correspond to the days. And the 4-dose schedule consists of 2 doses on day 0 and 1 dose each on days 7 and 21. And the alternative for fully immunocompetent exposed persons who receive high quality rabies immunoglobulin is 4 doses administered intramuscularly on days 0, 3, 7, and 14. But for intradermal administration, the administration of the vaccine is on days 0, 3, 7, and 28. This regimen may be used for people with category 2 and 3 exposures in countries where the intradermal route has been endorsed by national health authorities. The rabies post-exposure prophylaxis schedule in the United States for 2010 includes immunization status, treatment, and the regimen. So, for those who are not previously immunized, we usually do wound cleansing, cleanse all wounds with soap and water, irrigate wounds with 9:1 diluted solution of povidone iodine. For HRIG, we administer 20 IU per kilogram actual body weight. If anatomically feasible, infiltrate the full dose around the wounds and give any remaining volume IM at an anatomic site distant from vaccine administration. Do not give HRIG in the same syringe as the vaccine. HRIG may partially suppress active production of rabies virus antibody, so do not give more than the recommended dose. HDCV or PCECV 1.0 ml at the deltoid area with one dose on days 0, 3, 7, and 14 is the schedule for the vaccine. For those who are previously immunized, we also do wound cleansing, but we do not administer HRIG, and the vaccine, be it HDCV or PCECV at 1.0 ml at the deltoid area, is only given at one dose on days 0 and 3. So, Patients who are previously immunized are any persons with a history of pre-exposure prophylaxis with HDCV or PCECV, prior post-exposure prophylaxis with HDCV or PCECV, or previous immunization with any other type of rabies vaccine, and a documented history of antibody response to the prior immunization. Day 28 vaccine dose is no longer recommended unless the patient is immunocompromised. For persons with prior rabies immunization, if exposed to rabies, persons who are previously vaccinated should receive 2 intramuscular doses, 1 ml each of vaccine, one immediately and one 3 days later. Previously vaccinated refers to persons who have received one of the recommended pre-exposure or post-exposure prophylaxis regimens of human diploid cell vaccine or purified chick embryo cell culture vaccine, or those who have received another vaccine and had a documented acceptable rabies antibody titer. HRIG is unnecessary and should not be given in these cases because an amnestic antibody response will follow the administration of a booster regardless of the pre-booster antibody titer. Immunocompromised persons' immunization presents special challenges. First, the vaccines may represent a danger to the immunocompromised individual. Second, the immune response to vaccination may be insufficient. Higher doses or additional immunizations may be required, and even with these modifications, the immune response may be suboptimal. The severely immunocompromised are those who have congenital immunodeficiency, human immunodeficiency virus infection, leukemia or lymphoma, aplastic anemia or generalized malignancy, or those who are being treated with alkylating agents, antimetabolites, radiation, or large amounts of corticosteroids. Because rabies vaccine is formulated with an inactivated virus, it does not represent a danger to immunocompromised persons and may be administered to such persons using the standard recommended doses and schedule. However, a 5-dose schedule, which includes day 28, must be used in immunocompromised persons. The recommendations for the use of HRIG are the same for immunocompromised and immunocompetent persons. However, corticosteroids, antimalarials, other immunosuppressive agents, and immunosuppressive illnesses can interfere with the development of active immunity and predispose the patient to developing rabies. Immunosuppressive agents should not be administered during post exposure prophylaxis unless they are essential for the treatment of other conditions. When rabies post exposure prophylaxis is when rabies post-exposure prophylaxis is administered to persons receiving steroids or other immunosuppressive therapy, it is especially important that serum be tested for rabies antibody to ensure that an adequate response has developed. To confirm the adequacy of the immune response, serum collected 1 to 24 weeks after the post-exposure prophylaxis course should be completely neutralized or rather should completely neutralize challenge virus at a 1:5 serum dilution as measured by a rapid fluorescent focus inhibition test. If no acceptable antibody response is detected, consult an infectious disease expert and appropriate public health officials. Pre-exposure prophylaxis is recommended for certain international travelers based on the local incidence of rabies in the countries to be visited, availability of appropriate anti-rabies biologicals, and intended travel activity. These people include veterinarians, animal handlers, field biologists, spelunkers, missionaries, and certain laboratory workers. Chloroquine phosphate and possibly other structurally related antimalarials such as mefloquine, which is administered for malaria chemoprophylaxis, may interfere with the antibody response to intradermal rabies vaccine administered for pre-exposure prophylaxis. The IM route should be used for people taking chloroquine concurrently. Between 2001 and June 2010, 6 persons died in the United States from rabies after having been bitten by a dog, and another died after being bitten by a fox while visiting a foreign country. For this reason, all persons who have returned to the United States from abroad should be questioned regarding whether they have received an animal bite or scratch in an area with endemic rabies. Persons bitten or scratched by an animal in an area with endemic rabies should receive appropriate post exposure prophylaxis if the injury has occurred within the known incubation period, which may rarely extend up to 5 or more years. For pregnant women, there are adverse pregnancy outcomes or fetal abnormalities or rather for pregnant women, adverse pregnancy outcomes or fetal abnormalities have not been associated with rabies vaccination because of the potential consequences of inadequately treated rabies exposure and because adverse events have not been associated with rabies post-exposure prophylaxis during pregnancy. Pregnancy is not considered a contraindication to rabies post-exposure prophylaxis or HRIG. If there is substantial risk of exposure to rabies, pre-exposure prophylaxis may also be indicated during pregnancy. The dose of rabies vaccine for pre-exposure and post-exposure prophylaxis is the same in infants and children as in adults. The dose of HRIG for post-exposure prophylaxis is based on actual body weight. For small children with multiple bites, the calculated dose of HRIG may be insufficient to infiltrate all wounds. However, sterile saline can be used to dilute the volume twofold or threefold to permit thorough infiltration. Rabies virus causes acute encephalitis in all warm-blooded hosts, including humans, and the outcome is almost always fatal. Although patients with rabies may manifest a variety of clinical symptoms and signs, the disease tends to follow a characteristic course. Most commonly, the incubation period after a bite ranges from 20 to 90 days. However, incubation periods have been reported that are as short as 4 days and as long as 6 years. For patients who died from rabies in the United States between 1980 and 1996, and in whom a definitive animal bite occurred, the median incubation period was 85 days, with a range of 53 to 150 days. The incubation period is shorter when the site of the bite is on the head than when it is on an extremity. The clinical stages of clinical rabies after the incubation period include the prodrome, acute neurologic phase, coma, and death or recovery. Recovery being very extremely rare. The prodrome is usually defined by the first symptom, with a usual duration of 2 to 10 days. Common symptoms and signs include pain or paresthesia at the site of the bite, malaise, lethargy, headache, fever, nausea, vomiting, anorexia, anxiety, agitation, or depression. For the acute neurologic phase, the first neurologic sign defines this phase, and this usually lasts between 2 to 7 days. Patient may have anxiety, agitation, depression, hyperventilation, hypoxia, aphasia, incoordination, paresis, paralysis, hydrophobia, pharyngeal spasms, confusion, delirium, hallucinations, and marked hyperactivity. Coma occurs within 0 to 14 days with coma, hypotension, hypoventilation, apnea, pituitary dysfunction, cardiac arrhythmia, and cardiac arrest. When the patient has death or there's initiation of recovery, recovery can take up to months, even if it is very rare, and the patient may have pneumothorax, intravascular thrombosis, or secondary infections. During the prodrome, symptoms and signs are nonspecific. Early in the course, some patients may report symptoms suggestive of rabies such as limb pain, limb weakness, and paresthesias at or near the presumed exposure site. The prodrome merges into the acute neurologic phase, which begins when the patient develops objective signs of CNS disease. There are two clinical forms of rabies, an encephalitic form in 80% and a paralytic form in 20%. In encephalitic rabies, there are often episodes of generalized arousal or hyperexcitability, disorientation, hallucinations, and bizarre behavior, often separated by lucid intervals. Autonomic dysfunction is common and includes hypersalivation, hyperthermia, tachycardia, hypertension, piloerection, cardiac arrhythmias, and priapism. Paralytic rabies generally begins with paresis in the bitten extremity, with spread to quadriparesis and bilateral facial weakness. There is progression of paralytic rabies to coma and organ failure, typically with a longer clinical course than encephalitic rabies. About 50% of patients have classic hydrophobia, in which attempts to drink fluids result in severe spasms of the pharynx, larynx, and diaphragm. Coma almost always occurs within 10 days of the onset of symptoms. Death occurs due to a variety of complications, including pituitary dysfunction, seizures, respiratory dysfunction with progressive hypoxia, cardiac dysfunction with dysrhythmias and arrest, autonomic dysfunction, renal failure, and secondary bacterial infections. Only 7 patients are known to have survived rabies. In all but one, the patient had received either post exposure or pre exposure prophylaxis with a rabies vaccine before the onset of symptoms. Rabies should be included in the differential diagnosis of any patient with unexplained acute, rapidly progressive encephalitis, especially in the presence of anatomic instability, dysphagia, hydrophobia, paresis, or paresthesias. Diseases that may be confused with rabies include tetanus, poliomyelitis, Guillain-Barré syndrome, botulism, transverse myelitis, post-vaccinal encephalomyelitis, intracranial mass lesions, cerebrovascular accidents, poisoning with atropine-like compounds, and infectious causes of viral encephalitis such as herpes simplex, varicella zoster, arthropod-borne viral encephalitis such as eastern equine encephalitis. Emerging diseases that can be confused with rabies include the West Nile virus, Toscana virus, Japanese encephalitis, enterovirus 71, human herpes virus 6, chikungunya fever, Nipah virus, and the Hendra virus. The diagnosis of rabies is frequently made postmortem. This occurs because of the rarity of the disease, with the increasing number of persons without an obvious exposure and clinical confusion with other disorders. Important clues to diagnosis include the history of an animal bite or bat exposure and the development of pathognomonic signs of hydrophobia and aerophobia, precipitating grimacing and other signs by blowing air on the patient's face. During the incubation period of rabies, no diagnostic test is available for humans or animals that will indicate infection. Once symptoms become evident, antigen and antibody testing of serum, cerebrospinal fluid, saliva, and tissue such as the cornea, brain biopsy, and skin from highly innervated locations such as nuchal skin can detect evidence of the disease. Serum antibodies may be present as early as day 5 of clinical illness, but antibodies may be absent after 10 to 14 days or longer. CD of the brain is only useful to exclude other diseases. MRI of the brain may be normal or may show lesions in gray matter areas of the brain parenchyma, including the brainstem. Cerebrospinal fluid analysis often shows a mild mononuclear pleocytosis. No specific therapy has been of demonstrated benefit in clinical rabies. Treatment with rabies vaccine, rabies immunoglobulin, IV ribavirin, or interferon is not effective. In animal models, use of corticosteroids shortens the incubation time and increases mortality, and for this reason, steroids are contraindicated. Survival with normal neurologic function was reported for a 15-year-old girl in whom coma was induced and treatment with ketamine, midazolam, ribavirin, and amantadine was provided. However, similar regimens have been used for more than 20 other patients without success. Currently, treatment is directed at the clinical complications of the disease. Although rabies is not treatable, every attempt should be made to achieve rapid diagnosis because it justifies public health measures to limit contacts with a patient and permits reconstruction of a history to identify others who may have been exposed to the same infective source. So, as always, my reference is Tintinalli's Emergency Medicine. Thank you.